Well, very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part. Today, our guest speaker for the day is Professor Philippe Moreau from France, and he's going to lecture us on bispecifics in the treatment of multiple myeloma. This webinar is brought to you by Mumbai Hematology Group, supported by Jensen, Natco Oncology, Lucien Life Sciences, and Nirvin Life Sciences, and managed by Perfect Square. I thank Team Jensen, Natco, Lucien, and Nirvin, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Sudha Shetty from Cuttack. Our guest speaker for the day, Professor Dr. Philippe Moreau from France. All our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for spending a Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 26th of April 2025 from 7 p.m. Indian Standard Time and 9:30 a.m. Eastern Time, we have Dr. Henny Al-Samkari from Boston, Massachusetts, USA, speaking to us on immune thrombocytopenia from thrombopoietin receptor agonists to novel therapies. And the following date, it is Sunday, 11:30 a.m. Indian Standard Time, 27th of April 2025. We have Dr. Ria Balikar from Wockhardt Hospital, Nagpur, speaking to us on daratumumab-based treatment of newly diagnosed multiple myeloma. Let me introduce our discussions for the day, and they're displayed here in alphabetical order. I will pause for a while for you to have a look on all our discussions today. They are displayed here. So these are our discussions for the day. Now it's time to introduce our guest speaker for the day. We have with us no other than Professor Philippe Moreau from France. Professor Philippe Moreau is director of the Cyric Iliad, professor and head hematology department, University Hospital of Nantes, France. He is also the head of the translational research program in hematology and oncology at the University Hospital of Nantes, France. He has over 20 years experience in clinical hematology and has led many pivotal clinical studies. His interests are focused on multiple myeloma and his treatment with high-dose therapy and novel agents, including cell therapies. He has been the chairman of the Intergroup Francophone du Myelome, that is IFM, since 2020 and vice president of the International Myeloma Society since 2019. He has been a member of the steering committee of the International Myeloma Working Group since 2013. He has served as the principal investigator for many international randomized phase 3 clinical trials evaluating proteasome inhibitors, immunomodulatory drugs, as well as CD38 antibodies. He also participated in the study of idecaptogene briclucil, that is Abecma, that received FDA approval in March 2021 as the first genetically modified autologous chimeric antigen receptor CAR T-cell therapy for the treatment of relapsed refractory multiple myeloma. In 2018, Professor Moreau received the Robert A. Kyle Lifetime Achievement Award. He is a member of the Integrative Oncogenomics of the Pathogenesis and Progression of Multiple Myeloma team of CRCNA, directed by Stephen Minuel. He is very frequently invited speaker at international hematological and oncological meetings. He has authored as well as co-authored more than 400 peer-reviewed articles that have appeared in very high impact factor journals, including NEJM, JCO, Lancet, Lancet Oncology, and Blood. He is also the member editorial board of JCO, Blood and Blood Cancer Journal. And today is going to lecture us on bispecifics in the treatment of multiple myeloma. But before he does that, let me introduce our special guest and chief guest for the day. We have with us Dr. Sudha Shetty from Cuttack. Dr. Sudha Shetty is associate professor and head of department at Department of Clinical Hematology and BMT unit at SCB Medical College and Hospital, Cuttack, Odisha, which is one of the premium institutes gracing the map of this country. She did her undergraduation, post-graduation, and training in hematology under the very institute as where she works right now. She has had a 15-year-long experience in the field of hematology. She has been involved with many different research projects, clinical trials, and has more than 50 publications in national and international journals. She is a life member of IAPM, ISHBT, IMA, and has been serving as a proud Rotarian since 1999, and she's also a fellow of ICH. To her DNB and PG students, she is a teacher, full of fire and passion towards a profession, and always ready to guide her students in the process of thesis and publication. She has organized many patient awareness programs to facilitate treatment and patient health care and has always attempted to bridge the gap between the patient and healthcare providers. She has been a driving force in organizing several CME, workshops, and conferences in the state as well as on the national level. Her fields of interest are hemoglobinopathies and rare bleeding disorders. It's my privilege to welcome Dr. Sudha Shetty to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Sudha Shetty.
Good morning.
Good morning, ma'am. Please go ahead, ma'am.
Good morning, everyone. And thank you, Dr. Amit Khurana, for having a good, kind words for me. I'm honored to be invited as chief guest by Mumbai Hematology Group and also feel privileged for this opportunity. I really do not know. I don't think that myself worthy of imparting any words of wisdom when masters of masters are themselves sitting in this webinar. I know that it's a fact. Many of the boarding hematologists are attending this webinar from different parts of the country and also as well as from the other parts of the all over the world. Here a few words for them. This branch of hematology is rapidly progressing in both diagnosis and treatment. I remember back when I was doing my postgraduate, genetic and molecular study seemed like a dream to us. But in current scenario, diagnosis of hematological malignancies is practically incomplete without any molecular or genetic studies. Same as in treatment. In current state of affair, immunotherapy and targeted therapy are taking place of aged old chemotherapy and radiotherapy. CAR T cells is also going to be widely available for everybody. And gene therapy is also approved for sickle cell, thalassemia, and hemophilia. And also stem cell transplant has blossomed like anything. According to Indian Society of Blood and Marrow Transplant Registry, over 110 centers are popping all over the country. Although I am working in a government hospital in a small town of Cuttack, Odisha, we have performed more than 200 stem cell transplants, which includes auto, allo, mud, and haplo. Our first patient was a tailor by profession. And way back in 2014, we have started our journey. Until now, that patient is well and without any sign of relapse. My whole point is whether it is a small hospital or a world-class hospital, opportunities never cease showing up. You just have to catch the right opportunity at the right time to make a difference. It's very important that you have to document all your own data and try to publish them, and also keep yourself updating by attending this such type of seminars. As I conclude, I would personally like to thank Dr. M.B. Agarwal sir and Dr. Amit Khurana and also Mumbai Hematology Group for organizing such beautiful seminars and also giving a wonderful platform to all of us, including me, where we can interact with the national and also international faculties. Like today, the guest speaker is Professor Philippe Mouret from University Hospital Nantes, France. And thank you very much for giving me this opportunity. And virtually, I inaugurate this webinar. Thank you.
Thank you so much, ma'am, for the wonderful words of wisdom. That was really kind of you, ma'am. And thank you for accepting our invitation as our chief guest for the day. Thanks a lot, ma'am. And now, Dr. Philip Morrow, the screen is yours. Please go ahead.
So good morning, and good morning to all of you. And I'm sharing my screen now. So can you hear me well?
Yes, sir.
Okay, so let's speak about bispecific antibodies. You can see my disclosure. And first of all, you know that now that we are using CD38 antibodies such as daratumumab or isatuximab very early in the course of the disease, in fact, many patients will become refractory to PIs, to IMiDs, and to CD38 antibodies after 2 or 3 lines of therapy. For example, at the time of the frontline therapy, some patients are treated with the combination of VRD, autologous stem cell transplantation, and lenalidomide maintenance until progression. At the time of the relapse, we can use carfilzomib dex and a CD38 antibody, KD-DARA or KD-isatuximab, until PD as well. And after 2 lines of treatment, the patient is now refractory to lenalidomide, refractory to carfilzomib, refractory to CD38 antibody as well, after 2 lines of treatment. So what is the outcome of those patients that are triple class refractory when they are not treated with any new immunotherapy? These are the data from the US registry, US cohort, and you see that for triple class refractory patients, the median overall survival in the real life is 9 months only. Recently in Europe, we looked as well at the outcome of triple class refractory in this prospective cohort of patients, locomotion, and looking at 248 patients. That's really when patients are triple class refractory, we have used 92 different regimens in the real life. It means that there is really no standard of care. And we are trying to control the disease with different agents, alkylators, antibodies, PI, IMiDs in combination, and the response rate in triple class refractory patients is only 29.8%, 30%. So 1/3 of the patients are going to respond. And the PFS is very, very short, 4.6 months. And the overall survival is 1 year only. So definitely we need new agents. And this is one picture of what we can propose according to access and reimbursement in some, let's say, lucky countries for patients refractory to IMiD, PIs, and CD38 antibody. Probably the best treatment are anti-BCMA agents. And we can use either BCMA CAR-Ts or BCMA bispecific antibodies. BCMA, as you know, probably was discovered a long, long time ago, more than 30 years ago, by this team in Paris, and they immediately noticed that BCMA was only expressed in plasma cells with no expression on other tissues such as the kidney, the liver, the lung, etc. And BCMA was also always expressed on myeloma cells. So our colleagues at that time, 30 years ago, mentioned immediately that if we could target BCMA, probably we could kill the myeloma cells without any severe organ damages. BCMA is crucial for the survival of the tumor cells, but BCMA is also crucial for the survival of normal plasma cells. So when you are going to target BCMA, you are going also to kill the normal plasma cells, and you are going to induce immediately a very deep and severe hypogammaglobulinemia and a risk of infection. So currently, we are using those bispecific antibodies with one arm targeting a myeloma antigen, one arm targeting CD3 and redirecting the T cell in contact with the myeloma cells, and an FC portion that is crucial for the long half-life of the antibody, allowing a discontinuation administration of the bispecific antibody. In the future, we are probably going to use tri-specific antibodies that will be able to target two different myeloma antigens, for example, BCMA and GPRC5D. And at the next EHA ASCO meeting, we are going to hear very interesting results with new tri-specific antibodies. Or it will also be possible to target not only a T cell, but also at the same time an NK cell that will increase the activity of those antibodies. So what are the targets? What are the antigens on the myeloma cell? At the bottom of the slide, you see that BCMA is probably the most interesting one. But we can also target GPRC5D, FCRH5, CD38, SLAMF7, and so on. So different targets that are always expressed on the myeloma cells. So currently we have two bispecific antibodies that are approved, teclistamab based on MajesTEC-1 study and elranatamab based on the phase 2 MagnetisM-3 study. So tecli was proposed in 2022 based on the large phase 2 MajesTEC-1 study published in the New England Journal of Medicine. So this is the technology, a dual-body antibody with one arm targeting CD3 and one arm of the antibody targeting BCMA. This antibody is allowing a T-cell expansion and is able to target the myeloma cell, inducing a cytotoxicity. And when at first we tested this agent, especially in patients with high tumor burden, we were fearing an important toxicity with a cytokine release syndrome. So we started, in order to try to control the CRS, the cytokine release syndrome, we started to use a very low dose of the antibody and an increased dose 2 days later, what we are calling the step-up doses, in fact. And we are currently using teclistamab with the first dose of 60 microgram per kg during week 1, and then we are increasing the dose times 5 from 60 to 300 microgram per kg, and then the full dose 2 days or 3 days later, 1.5 milligram per kg. So that's amazing, you know, within the first week to increase the dose by 25 times, in fact, from 60 microgram to 1.5 milligram per kg sub-Q. And then subsequently, patients are receiving the agent weekly until cycle 6 and subsequently every 2 weeks. So this is the patient population of MajesTEC-1. 165 patients were treated, median age 64 years. And interestingly, 14% of the patients were very old. above the age of 75 years, indicating that this treatment is feasible even in very elderly patients. And the vast majority of them were triple-class refractory, and the median number of prior lines of treatment was 5. Overall, 2/3 of the patients are going to respond. The response rate is 63%. Keep in mind that in the locomotion study, the response rate in the same patient population was only 30%, in fact, in the real life, without any immunotherapy. And those responses are very quick, in fact. The median time to first response is 1 month. Median time to best response is 3.8 months. So very quickly, you will know if your patient is going to respond, yes or no, to this agent. Looking at different subgroups of patients, the responses are quite consistent across subgroups, but patients with an ISS3 or patients with extramedullary disease are enjoying a lower response rate that is roughly 40% and not 60%. The study was updated. The last update was reported last year at the International Myeloma Society workshop. And overall, the median progression-free survival is roughly 1 year. Interestingly, and that's the most important finding to my opinion, on the right-hand side of the slide, when patients are going to respond to the treatment, the median duration of the response is 24 months, 2 years. In fact, that's a very important information because when you are going to try to use this treatment in front of you, in front of the patient and the family, if the patient is responding, you can indicate that this response will last 2 years in median, and that's very important for sure for our patients. There was another cohort of patients treated in Asia, in fact, and when you are adding the patient population from Majestic-1 and the Asian patient population, we have a number of patients above, or roughly 300 patients, and the response rate is identical. The PFS is also identical. So we have all these registral clinical studies indicating that duration of response, roughly 2 years, PFS, 1 year, and overall survival in the intent to treat patient population from Majestic-1 is 2 years as well. But for those patients reaching CR, complete response in green, you see that more than 70% of them are alive at 3 years. So that's very important, in fact, since teclistamab could be very often the last line of treatment that our patients are going to receive. You know that Majestic was run during the COVID pandemic era, and then when we are censoring the COVID death, in fact, we are even increasing the PFS up to 15%. We are also improving the duration of response and the overall survival. We also looked at PK/PD modeling, to try to understand if we can reduce the number of administration of teclistamab. And definitely, with the dose of 1.5 every 2 weeks, after 6 months, we have the concentration of the antibody that is above the threshold that is considered to be the optimal one. So it is probably feasible to switch to Q2 weekly dosing, in fact, rather quickly when patients are enjoying a good response. So the second bispecific antibody targeting BCMA that is now available and approved as well Majestic was the pivotal study for the approval of teclistamab. We have magnetism-3, a large phase 2 as well, for the development of elranatamab. And this is the schedule and the design of the study. And ELRA was approved based on cohort A of magnetism-3 in patients who never received previously BCMA-directed treatment. The most important difference with elranatamab is that we are using a flat dose of the antibody and not a dose that is adapted to body weight. We are using 2 step-up doses of 12 and subsequently 32 milligrams sub-Q during week 1, and then 76 milligrams sub-Q weekly up to cycle 6, and then every 2 weeks thereafter. So the dosing schedule is quite similar to that of teclistamab, and this is the patient population of magnetism-3, 123 patients, median age 68 years, and also a very, very high number of patients triple-class refractory, 96%. So very heavily pretreated patient population. And the median number of prior lines of treatment was 5 as well. So the response rate is very, very similar to that of teclistamab, 61%, roughly the same, in fact. And again, same story. If you are looking at patients with ISS3, patients with extramedullary disease at baseline, when we started ELRA, and penta-refractory patients as well, the response rate is lower from 30 to 40% only. So we know that some subgroup of patients are benefiting less, in fact, from these 2 bispecific antibodies. The duration of response is also very, very good and was updated recently in different meetings. So the median duration of response is above 2 years as well. And this is the last update of magnetism-3 recently published. And the median PFS is 17 months, and the median overall survival in the intent to treat patient population is 2 years. So this is including all patients, not only patients that are going to respond, but this is really the intent to treat analysis showing, to my opinion, very good results. As mentioned previously, patients with EMD, yes, 38% of response, ISS3, 26% of response, penta-refractory, 46% of response. But if you are combining 2 adverse prognostic factors, in fact, some responses are very disappointing. For example, ISS3 on the left-hand side, plus high-risk cytogenetics, 0% of response. ISS3 plus EMD, 0% of response. ISS3 plus penta-refractory disease, 0% of response. So we can identify really a subgroup of patients, and that's the majority of them, that will enjoy a very good response. But on the opposite, we can unfortunately identify some subgroups of patients that will never benefit from these antibodies because the results are identical with teclistamab as well. So what about safety? When we started to use those bispecific antibodies, as I mentioned previously, we were really fearing cytokine release syndrome. And in fact, that's true that the majority of the patients are enjoying a CRS, 72% in the Majestic-1 study. But there is no grade 3 CRS and only grade 1 or 2. And grade 1 or 2 are really easily manageable in the routine practice. And those treatments are not only used in university hospitals, But in my country, the majority of community hospitals are using those bispecific antibodies quite easily. And this CRS is very predictable. The time to onset is 2 days, median, and the median duration of the CRS, grade 1 or grade 2, median duration 2 days as well. This is exactly the same for elranatamab, 0% of CRS grade 3 or 4, and 60% of CRS grade 1 or 2. What is the management of CRS? How to manage? In fact, we have very clear, very clear guidelines, published by the International Myeloma Working Group, or these are the guidelines from the European Myeloma Network group. Grade 2, you can use tocilizumab, 1 dose, 8 milligram per kg IV, and then the CRS will be controlled. Very, very few grade 3 that are needing, in fact, the admission to the intensive care unit. The most important adverse event for bispecific antibodies targeting BCMA are infections. Sorry. And those infections are occurring grade 3 or 4 in more than 40% of the patients into MajesTec, and the same for magnetism 3. Because, as I mentioned previously, we are targeting BCMA and inducing immediately after the first 2 doses of the antibody, we are immediately inducing a deep hypogammaglobulinemia. And this picture is showing that when we are reducing the number of infusions from the weekly schedule to an administration every 2 weeks after 6 or 9 months, the rate of infection is decreasing over time. We can use very easily, and we need to use, to my opinion, a systematic IVIG administration. And this picture also from the MajesTec 1 study is showing very clearly that when you are using IVIG, the proportion of severe infection is less than 20%. On the opposite, when you are not using IVIG, there is an increased rate of infection, and not only during the first 3 or 6 months of treatment, but you will reach almost 100% of severe infection rate after 10 or 12 months. So this picture is also showing that when you are switching to a monthly dosing, that is feasible, to my opinion, after 1 year of treatment, then you are immediately reducing the adverse event rates, GI disorders, infections, mostly. That's really the most important adverse event again. So what I'm doing in my routine practice, I'm using weekly until VGPR or CR, and then switching immediately to every 2 weeks. And after 1 year of treatment, I'm using the monthly administration of bispecific antibodies. Can we sequence, in fact, these agents? Because we do have some CAR-Ts that are available. In fact, in MajesTec 1, there was a cohort of patients, a small cohort of patients, with a prior treatment with a BCMA targeted strategy, such as belamaf, ADC, or CAR-T as well. Small numbers, but nevertheless, you see that after CAR-T cell therapy, the response rate is 50%. So 60% overall and 50% for a prior CAR-T cell therapy exposure. That's pretty good, I would say. But the progression-free survival is not that long, in fact. And this was published by my co-worker, Cyril Touzeau, a few months ago. The median PFS, when you are using Tecli, following CAR T-cell therapy targeting BCMA is 4 months only, and the overall survival was 15 months. For elranatamab, we also have some data of elra following BCMA-directed therapies, and the response rate on the right-hand side is also 50%, so the data are really consistent when you are comparing Tecli and elra. And the duration of response is not that bad, in fact, with elranatamab. Prior CAR T in green, duration of response seems to be above 1 year, in fact. And the progression-free survival with prior CAR T-cell therapy is 10 months in green, when elra is following a CAR T targeting BCMA. And the overall survival is 1 year. Small numbers, but this is indicating that we can probably use CAR T first and then bispecific antibodies at the time of the progression. More and more now, we have real-world data with bispecific antibodies. And this is the French experience with teclistamab, and we have treated more than 3,000 of patients with Tecli since the approval of this agent, and this is the first experience on the first 300 patients. And the median progression-free survival is 1 year, exactly the same results as compared with the pivotal study of the approval, MajesTEC-1, and the overall survival is quite good as well. So we can reproduce, in fact, the results of the pivotal study in the real-world practice. And this is the patient population, and the patient population, in fact, was more advanced as compared with patients enrolled in the MajesTEC-1 study, with more patients with extramedullary disease, more patients with older age as well, and some patients were also BCMA exposed, and overall, we have 46% of the patients that were not meeting the eligibility criteria of MajesTEC-1. So always in the real life, we are using a new agent in more advanced patient population. And when looking at some prognostic factors, and this is very true with other real-life data coming from the US or Germany, and now we have plenty. EMD is an important prognostic factor, and also poor cytogenetics with 17p deletion with a median PFS of 5 months, for example. And we also looked at patients with a severe renal impairment, and the median PFS is not that good. So this is the picture of patients with extramedullary disease. Yes, you see the big difference as compared with patients without EMD, and the data are very consistent with other real-life papers. Can we use these antibodies in patients on dialysis? Yes, this is feasible, and this is the experience, again, a very small cohort of the French population of patients, all of them on dialysis, and 14 out of 15 patients did respond to teclistamab. So this is really feasible. Tecli is an antibody, elra is an antibody, so you can use this in patients with severe renal impairment and even on dialysis. Do we have real-life data with elranatamab? We only have one paper published in Blood Cancer Journal last year, and this is again the first experience among 22 French centers, 101 patients treated with elra between 2022 and 2023. And again, the patients were much more advanced as compared with patients enrolled into the pivotal magnetism-free study. And the median OS and the median PFS seems to be lower as compared with the pivotal study for the approval, because of very, very advanced stages. You see here the duration of response, the median duration of response was 1 year only, in fact, in this very heavily pretreated patient population. Sorry. What is the outcome, in fact, of patients that are now becoming quad refractory? Quad means refractory to PIs, IMiDs, CD38, and BCMA. In fact, this is the experience of my center. We published this paper in the British Journal of Hematology. When patients are quad refractory, the median PFS is 4 months, median OS 6 months. So this is really the unmet medical need now. But you see on the right-hand side that there is a small subgroup of patients in red that are enjoying a better progression-free survival. So who are those patients? Those patients were all of them treated with a bispecific antibodies targeting GPRC5D, so another antigen. This is what we can propose, in fact, in our patients quad refractory. Of course, clinical studies, if possible, new CAR-Ts, if possible, or new bispecific antibodies, and one of them is now approved, that is talquetamab. And talquetamab is targeting GPRC5D, and it is the only antibody approved with this target. Talquetamab was developed in the monumental study published in the New England Journal of Medicine in 2022 and very recently updated a few weeks ago. So this antibody is targeting CD3 and GPRC5D that is also always expressed on myeloma cells. And the expression of this GPRC5D is less important on normal plasma cells. So the risk of infection is less as compared with Tecli and as compared with elranatamab. Two different cohorts of patients were treated in the monumental study, the dose of 0.4 milligram per kg sub-Q weekly or dose of 0.8 milligram per kg sub-Q every 2 weeks. You see that that was a very, very large phase 2 study enrolling more than 140 patients within each dose cohort. So this is the update analysis published a few weeks ago in Lancet Hematology. And you see that with the 2 doses, in fact, the responses were very good, and the response rate is even better as compared with Tecli and Elra, 70% overall. And the optimal dose, in fact, of talquetamab is 0.8 milligram per kg in the middle, and you see that the duration of response, median duration of response with this dose is 16.9 months, and the median progression-free survival is 11 months. So we are starting with the dose of 0.8 milligram per kg every 2 weeks. That is the optimal one. But in case of toxicity, we can switch and reduce from 0.8 to 0.4 milligram per kg, and the median time to first response is also very, very quick after 1 month, and the majority of the patients are going to respond. We know, looking at subgroup analysis, that again, same picture, patients with extramedullary disease have a bit of a shorter, much shorter progression-free survival, but we know also that this treatment is feasible in very elderly patients. On the right-hand side, you see that the best curve are for patients above the age of 75 years. Of course, that's the selection bias, but it means that we can use those agents again, Elra, Tecli, and talquetamab also in very elderly patients. Can we sequence from a BCMA treatment to a GPRC5D treatment. Into Monumental, there was a small subgroup of patients, 51 patients, that were previously exposed to a T-cell redirection therapy. And the response rate is 60%. So instead of having 70% of response, we have 60% of response. That is not bad, in fact, but the median PFS is short. And this is the median PFS of patients updated with a prior BCMA-directed bispecific antibody. And the median PFS is 3.9 months, 4 months only. So if you are using Tecli and Elra and subsequently talquetamab, you can salvage some patients, but the PFS is not that good, in fact, as compared to patients without any prior exposure to a BCMA-directed CAR-T. So what is the toxicity of talquetamab? Talquetamab is not only expressed on the myeloma cells, it is also expressed on the skin, on the central region of the tongue, and on the nails. So you will face a very new, let's say, specific toxicity with skin rash, with dysgeusia as well, with a dry mouth, with a sort of oral toxicity, and quite high rate of weight loss. So in front of this specific toxicity, the nail toxicity, the skin rash, the oral toxicity, and weight loss, we don't have a lot of things to do. In fact, the only thing that we can do is to stop the treatment and to wait for the recovery and then restart at a lower dose of 0.4 instead of 0.8 milligram per kg. We know that the risk of infection is less, in fact, with talquetamab. And when you are looking at the data in terms of infection, maybe we don't need to use a systematic IVIG administration. So what is the future? Probably the future is to combine, in fact, talquetamab plus teclistamab. And this is what was proposed by Dr. Cohen and published a few weeks ago in the New England Journal of Medicine. And when combining Tecli and Talque, targeting two different antigens, the response rate is amazing and very, very high. And at the optimal dose, the progression-free survival is very, very good as well, close to that of cilta-cel. And that's especially true in patients with extramedullary disease. So it means that you can combine Tecli and talquetamab. This combination is not yet approved, but there is a specific ongoing study looking at the combination for an official approval in patients with extramedullary disease. And probably this also indicates that in the future, tri-specific antibodies targeting both antigens will be very, very active. And to close, I will briefly mention the development of bispecific antibodies in patients with early relapse. And we know that we have this possibility in LEN refractory patients. Two studies are ongoing, no results yet. In fact, MajesTEC-3 is looking at TEC plus daratumumab versus standard of care in patients with 1 to 3 prior lines of treatment. There is MagnetisM-5 also looking at elranatamab alone or in combination with daratumumab versus standard of care in patients with at least 1 prior line of treatment. And all those patients are LEN refractory. And we also have these two trials for LEN and DARA refractory patients, and ELRA and Tecli are compared with standard of care with a primary endpoint of progression-free survival. So Since those agents are very active in end-stage disease, they will be probably more active as well at earlier lines of therapy. And some trials are looking at bispecific antibodies in the frontline setting. And we have heard about the first cohorts of patients treated with Tecli plus Dara plus lenalidomide. So instead of using DRD, Lendex, Dara frontline, we can use Lendex plus a bispecific antibody. And the goal of those trials is to improve on the results of the Maya study. And we have exactly the same magnetism study, phase 3 randomized comparison of DRD, that is one of the standard of care in frontline ineligible patients for high-dose therapy, DRD versus ELRA, Daralen. So interesting data for sure, and those trials are ongoing. And another last example of what we are doing with the French group in transplant eligible patients. This is a phase 2 study, VRD daratumumab upfront, a quadruplet combination frontline, and then based on MRD results after induction, we are proposing TEC plus lenalidomide or TEC plus talquetamab 2 years instead of autologous stem cell transplantation. So maybe bispecific antibodies will replace autologous stem cell transplantation in the future. And this is the phase 2 study, just a sort of proof of concept. So I would like to thank you for your kind attention today.
Thank you, sir. That was very, very clear lecture. It was crystal clear. And the way you teach us actually is fantastic, sir. Sir, do you have time for one or two questions, or should we come to an end to it? What do you feel
I
like?
have time for a couple of questions because, as you know, this Sunday is Easter Sunday in France, and that's a very important day for the family. So, but very happy to take a couple of questions for you now.
Thank you, sir. So I request the discussants to please put their hand raise sign so that we can start some of the questions with Dr. Philip Moro.
Can I start questions? Good morning,
Yes.
Dr. Moore.
Good morning, Bangaj. Good to see you.
Good to see you too, and happy Easter.
Thank you.
So you mentioned about teclistamab, works poor in patients who have extramedullary disease. So currently we have a patient who is penta-refractory post-transplant, and he is presented with a left pleural effusion. And the pleural effusion is showing infiltration by myeloma by flow cytometry, as well as the light chains are elevated. So he is on teclistamab, but we were just debating the pleural effusion is not going down. So we were just debating, can we put a small dose of teclistamab into the pleural fluid?
To my opinion, that might be feasible, but we don't have any data. So this is not something that they will do for sure, since no data available. So well, that's terrible case for sure, you know. So how to improve on teclistamab, you know, or on elranatamab alone? As I mentioned, probably the best way is to combine with another antibody. Talquetamab, unfortunately, is not available in France. It is not yet reimbursed, but I know that in Germany, for example, they are using the combination of Tecli and Talque quite frequently. Or if you have extramedullary disease, for example, on the skin or in the liver, you can use radiotherapy plus, you know, a monoclonal antibody. For this pleural effusion, that's probably difficult to add radiotherapy to this agent. But well, I cannot help you a lot on this one, you know.
Now we are really facing this problem because otherwise his AM band has gone down, light chains in the serum has gone down, but the effusion is still persisting and is
Yeah.
symptomatic. So because we thought that some physicians have put bortezomib into the pleural fluid, and the it has worked very well. So we were just thinking whether anybody has tried putting
Yeah.
some amount of teclistamab.
I'm not aware of any published case, such as your case now.
Right. Thank you. Thank you so much. Thank you.
Thank you, sir. Any other question? Any discussions have? So, I think,
Hello, good afternoon.
yes, Dr.
Hello.
Yeah. Yeah, please.
So, Dr. P. Muru, it was a very excellent presentation, and I am working in a small town and try to treat the hemophilia patient on village also with bortezomib or thalidomide or lenalidomide and dexa. But in the era, as you know, there is no cure till now, and we are struggling, even struggling with the bispecific CAR T cell therapy. So, to give the best possible treatment in a small town like Patna or in because I give the drugs to the patient to get bortezomib in village also, and that is possible with bortezomib or lenalidomide, thalidomide, and dexa. So when you are using, it is very interesting to know the mode of action of bispecific agent. But when bispecific agent use, there is hypogammaglobulinemia, there is chance of hypotension. So it should be given in ICU setup or as an inpatient, or it could be given in the outpatient also, OPD basis.
You mean IVIG replacement?
Yes, ICU is essentially needed to give the bispecific antibodies, or it
Well,
could be
in fact,
given daycare
yeah,
center.
yeah. In fact, you can, with bispecific antibodies targeting BCMA, definitely you should use, if possible, if you have access, etc., because we know that there is also a shortage, of IVIG. So you should use if possible. And for other combinations, when you are not using bispecific antibodies, I'm not using a lot in my routine practice. If you're using VTD, for example, and you were mentioning bortezomib, thalidomide, and dex, I'm never using IVIG. The depth of immunosuppression is really less as compared with BCMA agents. That's really for BCMA therapy that we need, in fact, to use IVIG.
Till now, as per my experience, real world experience, I faced the very poor of the poorest patient. I try to give the best quality of life of myeloma. So, you are agree that the steroid still the denominator basic drug that should be combined with any other drug that till now is available for the treatment. Without steroid, you can't treat the patient of myeloma, even by if the patient treated by a specific any steroid should be given in combination to have a better response to even decrease the rate of cytokine release syndrome.
I didn't understand very well your question. Really sorry.
The steroid, importance of steroid in the era of bispecific antibody treatment or in the era of CAR T cell therapy. The treatment of treatment of myeloma as a combination of drug or to mitigate the adverse effect of other drugs also. So
No,
importance of steroid. Yes.
yeah. We are always using combinations. That's really key. I believe that we have plenty of data comparing 2 drugs versus 3 drugs, and 3 is better than 2. The standard of care, in many countries when you don't have access to new
Yes.
agents, is bortezomib that can be generic, thalidomide or lenalidomide, so an imidopyide and dexamethasone, VTD, VRD, that's probably the best combination that you can use. If you have access then to CD38 antibodies, we know that, for example, quadruplet with the
Yes.
VTD DARA or VRD DARA are better as compared with triplet as well. So always combinations. Triplet is feasible. And well, I believe that in your country, you have also access to a lot of generics. lenalidomide generic, that's not that expensive. Bortezomib is generic as well. So if you can use VRD, that's very, very active for sure, you know, and we have data comparing VRD versus VRD auto with quite good results with a triplet with VRD alone, for example.
Okay, thank you. Thanks a lot for excellent presentation. Thank you.
So I would like to simplify
you,
Dr.
sir.
Suraj's questions. He had asked two questions on two specific bases. One is when you're using bispecific antibodies, and the risk of CRS is about grade 1, grade 2 CRS is about 70%, and for high risk is about high grade CRS is 30-40%, right? So is there any role of giving steroids prophylactically beforehand when you're using a bispecific antibody upfront?
Yeah.
Any
To
steroid
my opinion, you
to
know,
prophylaxis?
we should
Yeah,
not
prophylactic.
you should not use. Yeah, I understand. Sorry. We should not use bispecific antibodies if we don't have access to tocilizumab. Because, okay, you can use dexamethasone that is proposed, in fact, to control CRS. But the most active agent is definitely an anti-IL-6 antibody. So toci is the best. Because if you are only have access to dex, your grade 3 CRS will be much higher, in fact. And grade 3 CRS, it means intensive care unit, you know. So I believe that dex alone is not as active as toci. So I will not use bispecific if I don't have access to toci. That will be dangerous, to my opinion.
Exactly. His second question was whether to use bispecific antibodies in daycare setting or in ICU setting is must to go for bispecific antibodies. Do you require, can be given in daycare setting also? You can give. We can give a
Yeah,
bispecific antibody in daycare also, yes. So Dr.
yeah,
Subhas
yeah,
will
yeah.
also give in daycare settings
Yeah,
also.
this is well, we have a lot of programs now, you know, looking at the outpatient setting. When we started to use bispecific, all patients had to stay in the hospital during 1 week, in fact. But now we are developing outpatient administration with this step up that's feasible. And also um, we can use prophylactic tocilizumab, you know, that is, we have some papers, you know, looking on prophylactic toci. So this is feasible. I would not say that you should not avoid systematically bispecific if you don't have tocilizumab. Maybe I could rephrase this a little bit. In some centers, you know, patients are in the outpatient clinics, they have one pill of Dex, 20 milligrams, and as soon as they have some fever, they can take, you know, this pill of dexamethasone, 20 milligrams immediately. But, you know, the risk of infection is remaining high. So we need to be very, very, very careful, you know.
Exactly. Thank you, sir. And last two questions we'll take for you. One question has come from Dr. Prem. This is just a repetition that whether bispecific antibodies will replace the autologous stem cell transplant in future.
Well, we will have soon some trials comparing, you know, high dose and autologous stem cell transplantation versus a quad followed by bispecific antibodies. This study will start in France very soon, a prospective comparison of bispecific versus high dose and autologous. We did the same for CAR T-cell therapy. You know, the CARTITUDE-6 study is ongoing, comparing cilta-cel versus autologous. So this is probably where we are going to go in the future. Yeah.
Thank you, sir. And last question is that in which subgroup of patients will you prefer BCMA CART as compared to BCMA bispecific antibodies?
Oh, that's definitely a very good question. When you are looking in terms of efficacy, if you have access only to ide-cel, the ide-cel is probably as effective as bispecific antibodies. If you can have access to cilta-cel, definitely I will choose cilta-cel. That is probably much more active. But the issue of access and cost, you know, with cilta-cel is a big one. We still don't have cilta-cel in France, you know, so.
Thank you, sir. So the sequence would be like Siltacil, better, then IDCL, then
Yes,
your bispecifics. Yeah,
exactly,
that
exactly,
would be the-
exactly. Fully agree.
Thank you, sir. So we'll not take much of your time now.
Thank you so
It's-
much. Thank you.
Thank you so much, sir, for a fantastic lecture. Lovely discussion. We learned a lot
Thank
from
you.
you, sir, as always.
Thank you. Thank
you
you.
so much.
Have a good
Thank you.
meeting. Bye. Take care.
Thank you. Bye.
Bye bye.
Bye bye. Thank you.